Good afternoon, all. So, a warm welcome on behalf of Client and Indian Chess Society. So, I'm Dr. Pankaj Sononi from BI Medical Affairs team from the Respiratory Division. First of all, I would like to thank Dr. Swarnakar and the Indian Chess Society for providing us this opportunity to collaborate with them and plan this webinar, particularly the management of pulmonary fibrosis. So, a brief about the Indian Chess Society. So, ICS is an apex body of Association of Chest Physicians in India, which acts as an advocacy group to policies regarding diagnosis and management of respiratory disease. So, for this webinar, we have discussing about, is it correct or what? Okay, okay, sorry, yeah. So first, the topic would be management of IPF. It would be taken by Dr. Rajesh Swarnakar. Followed by management of SSC-LD, it would be taken by Dr. Sujit Rajan. And lastly, we will have Dr. Prahlad Prabhu Desai talking on pulmonary rehabilitation. Followed by we will have a 30 minutes of Q&A session. So I would request all the panelists who are joining this meeting, so kindly post your question in the Q&A box. We will take those questions at the end of the presentation. So with this, I would like to introduce Dr. Rajesh Swarnakar, who, who is the speaker for first topic, that is management of IPF. So Dr. Rajesh Swarnakar is the Director and Chief Consultant at Gateway Hospital and Research Institute at Nagpur. So he is a bronchoscopist and interventional pulmonologist and management of asthma, COPD, and interstitial lung disease. He has also interest in rehabilitation along with management of complicated emphysema and thoracoscopy. So today, Dr. is also a member of governing body of the Indian Chess Society and is an honorable pleasure.
So, so I think
Oh,
so.
is it correct?
Pankaj,
Sorry,
sorry,
sorry.
Pankaj,
Yes, yes, sir.
if you just put off your fan
Yeah,
because
sure, sure, sir.
if the
I'll
fan
do it
is
right away.
because the fan is there, there is a problem with the sound.
Okay, sure. I'll do it right away, sir. Yes, I'll do it. Okay, so to call Dr. pulmonary fibrosis. Over to you, sir, Dr. Swarnakar.
Thank you for my nice introduction and inviting me to deliver the talk on idiopathic pulmonary fibrosis. So it's intriguing to note that basically fibrosis is a common pathway to organ injury and also failure, which actually results in one third of deaths worldwide. So fibrosis is a common pathway to all organs, or I can say many organ failure, and it causes about one third of deaths worldwide, and hence it's an attractive therapeutic target. And contrary to the widely held perception that scar tissue is permanent, the available evidence points to the highly plastic nature of organ fibrosis, which is quite moldable with the current therapeutics. So, IPF and ILD are among the rarer causes of lung diseases, and is included in the orphan lung diseases. But still, all of these orphan diseases, in fact, account for 30% of all lung disorders. And hence, they form an important clinical aspect in our daily practice. So if we come to the IPF prevalence all over the world, the prevalence varies from 9 to 45 cases per 1 lakh population. It is much more in US, with a modest estimate of, if you assume conservative prevalence of 1 lakh. In India, the prevalence would be about 1,30,000 IPF cases. And if you take it a more generous estimate of 42.7, which was there in the article by Dr. Ganesh Raghu, per lakh population, then about 5,55,000 IPF patients are there in India. And this estimate is across all the ages. So if you take the age of more than 65 years, then of course prevalence can shoot up to 90 to 100 cases per lakh population. So the problem with IPF is that it is associated with frequent misdiagnosis. And there is also considerable delay in the diagnosis, which was actually told in an online survey. And it was revealed that the survey was done by US residents. And it was found that about 55% of those who were surveyed having IPF were misdiagnosed the first time they had gone to a doctor. In fact, 38% of them reported basically misdiagnosis even after 2 of their consultation with the doctors. And even if they were diagnosed, the median time which led to their diagnosis, which wasted the time, in fact, was about 11 months. So this shows that the awareness about existence of IPF has to be increased. And the story is same in India, that we of pulmonologists do see such cases in which IPF has been misdiagnosed most commonly as tuberculosis, and we often see them quite late in their disease. So when do we suspect the IPF or ILD for that matter? So it's quite simple. If a patient has exertional shortness of breath and or is associated with chronic cough, you have to just listen carefully to the classical late inspiratory crackles. You have to examine the digits for presence of digital clubbing, joints for evidence of autoimmune disease. You can order spirometry, which will predominantly show the restrictive curve with FEV1 and FVC decreased. DLCO would also be decreased if you order that. You order a chest X-ray and see the prominent interstitial lung markings. And if you can do an informal hallway walk, or if you just walks inside your clinic, you would see that desaturation of more than 3% is there, which is abnormal in our daily life. And if you find any of these, order an HRCT, which is most probably in most of the cases would diagnose ILD, and for that matter IPF also. And there are excellent papers which are there to guide you. So this is one on American Thoracic Society documents, which was published in 2015, which has given this clinical practice guidelines in treatment of idiopathic pulmonary fibrosis. And there is one another by Frischner Society white paper 2017, which actually gives you diagnostic criteria for idiopathic pulmonary fibrosis. And you can take a proper history and do an algorithm based on these questions. And you can diagnose a systemic autoimmune disease, other systemic diseases like sarcoid. You can ask some questions which are relevant and would be helpful in diagnosing hypersensitive pneumonitis. For example, is there exposure of home or work environment? Is that exposure clinical significant? Is the intensity clinical segment is also significant? You have to, of course, go for an occupational and environmental lung disease, because pretty pretty much they can cause ILD, interstitial lung disease. So what is their current jobs and previous job? This has to be elicited in the history. If there is a vocational exposure exists, you should take a history of drug history, and not only just allopathic drugs, but as happens in India, also take, if they are taking some non-allopathic medicine, herbs, or some of our supplements, recreational drugs that could account for the presence of lung disease. And of course, history eliciting a family history of lung fibrosis, which is a heritable cause, should also be there. So this Fleishner Society white paper also gives diagnostic criteria of a usual interstitial pneumonia based on CT pattern, which can vary from typical to probable to features which are inconsistent with an IPF diagnosis. And this can be done by having the distribution and features. So a basal predominant subpleural of distribution is quite typical. Honeycombing reticular pattern with peripheral traction, bronchiectasis or bronchiolectasis is quite typical of EIP pattern. While upper lobe or mid lobe predominant fibrosis, peribronchovascular predominance with subpleural sparing, or any of the following like predominant consolidation, extensive pure ground glass opacity without acute exhibition, extensive mosaic attenuation with extensively sharply defined lobular air trapping on expiration, and diffuse nodular cyst are inconsistent with diagnosis of IPF. But there exists a subset of patients whose CT pattern are indeterminate for UIP. And these are the patients who require further workup than just doing HRCT chest and may require basically lung biopsy. So before you read HRCT film, please see that if everything technical is proper with that film. So see that in all cases there is a breath hold so that there is no breathing artifact. The CT has to be taken in full inspiration. You should have both inspiratory and expiratory images. We had to have a thinner films, 1 mm of thin slide using a high resolution algorithm. We take this volumetric acquirence of the images, which should be there in a CD or a USB, because you have to go through various films, and this may not be there in a proper film format which can be carried by the patient. So it's always preferable to have these all these images in a USB or a CD. And if it is in films, then don't just basically conglomerate all the images in one film. It has to be only 12 on one format. And in select cases, to differentiate from the causes of interstitial lung disease, which are mimic, just like collapse of lung or atelectasis in the dependent region, you have to sometimes take the prone images in which this atelectasis or this lung collapse will just seem to disappear, while ILD or IPF won't. One more, of course, favor you can do to your radiologist is to provide him the information which should be communicated to your radiologist, which will help in the diagnosis. Like if suppose patient is a smoker or not, if there is a CTD present, if there's some connectivity disorder, you have found some symptom signs of that. If there's any other systemic illness that would have a bearing on the diagnosis, like HIV, and as I mentioned in my previous slides, occupation is the one history that you should elicit in diagnosing IPF. So these are interesting developments which has happened in management of IPF, and molecular evaluation of molecular biomarkers will have become increasingly important in the time to come. And these are genetic allelic spectrum, which are detected by personal genomic study, like techniques are next generation sequencing and genome-wide association studies, which actually presents would actually tell us about the presence of IPF, and we can differentiate IPF from ILD. Even this, we will call for genetic testing, which is not recommended for each and every patient, but only those who have got family history of idiopathic interstitial fibrosis, or if suppose disease onset is there before the age of 18 years, in which we go for genetic testing for suffected mutations, and if it is positive, then we go for this peripheral blood telomere length of testing, and also see if there are some mutation on this telomere, which will actually tell us about this heritable cause of IPF. Uh, Another interesting and very futuristic development which is happening in diagnosing of IPF is combinational approach with circulating of proteins, which may be diagnostic of ILD, and this has been studied in patients who are IPF with healthy control, and it may also lead to alternative diagnosis of ILD other than IPF. And these are actually biomarker studies which would actually postulate the presence of surfactant proteins, MMP7, osteopontin, and it enhances the diagnostic accuracy in patients with IPF compared with those with non-IPF ILD, and would aid in your diagnosis further. There is also possible of classification of UIP in patient with ILD by assessment of a machine learning approach using high dimensional transcriptional data, which can develop an algorithm again to help us. And this is very helpful in the sense, and it's of course a developing science, and it can also be done in also transbronchial samples apart from the blood. And if we can subject this tissue to this analysis, we have actually isolated various molecular biomarkers which are there, NCIP, SE-F, an array of them, which of presence would tell us whether this is IPF or non-IPF ILD. And you have to take about 4 to 5 tissues of TBB, so more is better, and fixing 5 of samples would be the best to detect. And in times to come, this would be the one which can be used often in diagnosis of IPF, and also distinguish it from non-IPF ILD. So what would be the futuristic diagnostic approach would have looked like? So you would suspect an ILD based on signs and symptoms. Then you would do a chest HRCT. If it is consistent with IPF, then of course there is no need to go for further, of course, workup. But if there is some indeterminate variety, then you have to go for bronchoscopy, blood and urine. You have to go for surgical lung biopsy. You have to resort to multiple disciplinary discussion. MDT, which is quite helpful, in fact, in which there is actually a radiologist and also a pathologist along with a pulmonologist who deal with the cases collectively, and this can pinpoint the diagnosis without any surgical intervention. Otherwise, of course, we can subject this tissue and blood to, of course, molecular signatures that I have just talked about, which is just developing. And then you can isolate, and we can actually give them pathway-specific therapy. And these pathway-specific therapy, area of it are being developed, which I will tell you in my, of course, talk subsequently. So we come to the proper IPF disease management, and there are 2 drugs which are proven to slow the progression of IPF, and we should actually not give many drugs which are harmful, which were given in the past. So just to briefly, pirferidone and nintedanib are the drugs which are there, along with adjuvant therapy of antacid therapy, which has been proven to be helpful in managing IPF. There is basically a recommendation which is against the use of triple therapy, which was there prevalent before 2015, like azathioprine, N-acetylcysteine, and prednisolone. In fact, they have been told that this therapy actually causes more harm in terms of side effects than of helping in actually managing IPF. So there is a strong recommendation against its use. So we come to the 2 antifibrotic medications, nintedanib and pirfenidone, which is recommended for the treatment of patients with idiopathic pulmonary fibrosis in Hallmark 2015 IPF evidence-based guidelines. And efficacy-wise, it is noted that nintedanib causes slow rate of decline in FVC over 1 year when compared to placebo, and it also reduces in acute exacerbations. It has got lower all-cause of mortality at 1 year, and some ongoing trials, which are real-world studies, have told that it actually adds about 5 years in the life of a patient of IPF whom they were just followed up. And this is extrapolation of actually a model which was told. Well, of course, pirferidone it also slows the rate of decline in FVC over 1 year compared to placebo. It also reduces acute exacerbations. There is a improved progression-free survival, and it also reduces respiratory-related hospitalization. I think the side effects of both the drugs are almost pretty comparable, with, of course, pirfenidone causing additional actually photosensitivity, and you have to advise patients to have sunblock creams and avoid exposure to sun. And we may have to stop a drug temporarily if there's rashes, of course, troublesome. There are absolute contraindication for both the drugs, but the cautions in patient with high cardiovascular risk or high risk of bleeding in of nintedanib. And dosing wise, if you see both the drugs, the nintedanib has got advantage of just a capsule to be taken twice daily, while pirfenidone has got a higher, of course, pill burden, and the dose achieved, or target dose achieved, may need more pills. But in this COVID era, we have some companies coming up with tablets of higher dose, and 801 mg per tablet dose is available. And if there's impact on of QOL and symptoms is there with both the drugs. In nintedanib, thus it slows the rate of decline in respiratory specific quality of life questionnaire as measured by SGRQ. While pirfenidone, we see the reduction in cough counts and significantly reduces worsening of the breathlessness. So first, I would tell you about pirfenidone. There were these phase 3 clinical trials of pirfenidone for the treatment of IPF was done in the trials, which started with a Japanese trial and was continued with capacity and ASCEND trials. And the data that we have actually contributed to our clinical practice of giving pirfenidone in patients of IPF. The dose required is 2,403 milligram daily, which was in the ASCEND trial, and not less. And there was a intermediate mean change in percent FVC when we give higher dose of 2,403 milligram per day in these patients who received pirfenidone. Continuing pharmacotherapy in IPF is a challenging thing because it might have to be taken lifelong, and hence compliance is to be there. Patient has to be advised and consult. We had to spend, of course, our time in communication with the patient, and doctor-patient relationship comes into play here. Not only pharmacotherapy, but go for a holistic approach for treatment of idiopathic pulmonary fibrosis. And this means that you have to refer your patient for also pulmonary rehab. So pulmonary rehab for IPF, ILD, if you can have some physiotherapy who specializes in this, and it will be quite better for his also well-being. And of course, which drug to choose actually depends in our country on economy, of course, and it depends on who's paying. In India, mostly patient has to pay from his own pocket, and hence, although this factor is not a problem abroad, but this can be a factor in prescribing which of the two tablets in India. So this is a trial which was done, and patients on pirfenidone were actually followed up for 5 years, and only about 50% of the patients who were prescribed were actually continuing the treatment. And hence it's a challenge in all the therapies that is to be given on long-term basis. And this is another study which was done on pirfenidone associated with reduction in relative risk of mortality versus, of course, placebo. So pirfenidone has shown also relative risk of mortality being also reduced when we use it. And this was all across the patients. It is very helpful to understand that there are basically 3 phenotypes of IPF that we deal in with patients. And once this lung microinjuries happen and patient develop IPF with onset of symptoms, he can either go down with having having a very rapid progressive course, or some of them have slow progressive course within between acute exacerbations, 1 or 2 exacerbations. And after exacerbation, it is seen that they will, of course, deteriorate very further. So preventing exacerbation is again a very important goal in management of IPF. And there are some people who are in between, and these are mainly patients who are actually ex-smokers and IPF and emphysema patients. So either of these, so any of these three uh, phenotypes can happen in your patients. And new data on benefits with pirferidone on respiratory-related hospitalization has been released, and it shows that pirferidone reduces respiratory-related hospitalization in idiopathic pulmonary, of course, fibrosis. This was a study which was done and was published in 2015 in the Blue Journal. So long-term observational studies, and these are observation and studies which are still going on, which are post-marketing surveillance, and discontinuation is mostly based on GI symptoms of nausea, diarrhea, and sometimes photosensitivity and rash. In such cases, basically you have to stop the drug for a while, and if it's not going on, then you can readjust the drug. You can have a drug challenge. You can adjust the doses, and can again give it. And it all depends on tolerability of the patient. Now we come to the nintedanib, which has got extensively studied in various trials, and the main trials that has given us the data for its clinical use comes from this 3 trials of Impulses 1, Impulses 2, and Tomorrow. And it's very heartening to know that nintedanib also is going on for real world studies, which are still continuing, which are open label and are being given to the patients once they have participated in some of these trials. And we got a very robust data available for use of nintedanib. And all these data points that there is a definite annual decline in the FVC, which it arrests if we use nintedanib, and the arrest of this annual change in FVC also decline is quite significant, and to be used in patients even when their FVC is more than 90% predicted. So this is very important fact that has come from the Impulses on trial, which is open label trial still going on. And hence it argues against a wait and watch approach, because even these patients with a preserved lung function in future can actually benefit from just starting, and they've been quite early in their disease program, and it supports the importance of prompt diagnosis. And it has been revealed that patients with severely impaired FVC may receive the same benefit from nintedanib on reduction in FVC decline as patients with less severe impairment. What about antifibrotics in acute exacerbation? It has been extensively studied in Impulses trial and Tomorrow trial, and a pre-specified sensitivity analysis of pooled data on time to first adjudicated acute exacerbation actually showed a significant benefit with nintedanib when compared with placebo. Of course, managing side effects of these drugs is of utmost importance, and the most important aspect is that you have to manage this adverse drug reaction, adjust the doses, and sometimes you have to pause basically the drug for a while, and then adjust the doses to then also lower if it is causing problem, and then you can restart the drug. In fact, the most important instructions that you can give to your patients while your patients are on these drugs is to take the drug actually with the food, and also just give some prevention therapy for its GI side effect. If suppose patient is on pirferidone, then as I said, you have to ask him to apply sunscreen, avoid sun, and also monitor the liver function test for any adverse event. So of course, active, I think, preventive strategy is also required when we are dealing with these drugs which are used for treatment of IPF. There's a very interesting association which has been which is categorically demonstrated in various studies, and which is a link between like macroaspiration and IPF, and which shows that ongoing actually stimulus of damage by aspiration of acid actually leads to also fibrosis in the lung, and it causes granulomatous pneumonitis, and then leads to dysregulated wound healing, which leads to pulmonary fibrosis. And its prevention definitely helps enough managing this IPF patients, which was basically also studied in a gastroesophageal reflux medication, has been associated with longer survival, has been proved in an article which actually published in this Blue Journal. And hence giving antacid therapy along with IPF drugs seems to be a very viable and kind of useful option, which has been also published in the Lancet in 2016. So apart from antifibrotics, how can we help our idiopathic pulmonary fibrosis? Not only drugs, but you have to go for symptomatic management of cough and also anxiety, because it is a disease which for which treatment is to be taken lifelong. It can cause pretty well anxiety and is to be managed. After breathlessness has to be managed, and these patients will also have associated many other heart or other problems like diabetics and this patient. So you have to manage this also comorbidities. As I said, that these patients has to refer and have to be subject for exercise and pulmonary rehabilitation. If suppose drug is not helping, then you have to resort for palliative care and can refer them for early lung transplantation. So it's very important that you share decision making with the patient, and you have to take into consideration the clinical inputs, what are the treatment options for that patient, risk and benefits, how to also manage its of side effects. We can just prophylactically give some therapy to actually prevent these side effects. And the patient's input is also needed in terms of his preference, in terms of when you ask him, when you just tell him side effects, is also tolerance to the drugs and its doses. And there are various concerns, for example, whether I should take this, of course, medicine for lifelong, and they have to be counseled on that aspect too for better compliance. So you have to settle treatment expectations while you talk with the patients. You outline the potential side effects of the medications, and we should actually find ways and means to deal with the side effects as after when they arise by your dose reduction, dose holiday, full dose titration, and emphasizing on importance of food intake along with the drug. And all these accounts to process is of slowing the disease, as loss of function impacts the survival in idiopathic pulmonary fibrosis patients. In the last few minutes, I would emphasize very good use of nintedanib in SSc-ILD, and this has been studied in Sensex trials, which has been also published in journals, and our center was fortunate to take part in this study. And there is an ongoing trial which is open label, which is still going on the use of nintedanib in SSc-ILD. And if I tell you why it's useful, let's us revisit the inflammation and fibrosis pathway that happens to be a common pathway in all the interstitial lung disease. So there is a direct injury and there is a cystic injury which causes lung inflammation. If suppose this stimulus clears rapidly, then there is no chronic inflammation, no structural damage, and of resolution is happen, and it's reversible. But because of some reasons, if this stimulus is persistent, this damage, this injury is quite persistent, it leads to chronic inflammation. And then you got activation of those pathways, which will lead to fibroblast inactivation, and also ECM reabsorption is affected, causing fibrosis, which can lead to irreversible loss in lung function and unhospitalized deterioration. So inflammation results in acute injury and spontaneous resolution, but severe injury could result in diffuse lung damage, derangement of alveolar architecture, which ultimately results in fibrosis. So this nintedanib has an antifibrotic activity that we know in various animal models of fibrosis. It has got anti-angiogenic and also anti-inflammatory effect. And there are commonalities in the pathological pathways involved in fibrogenesis in SSCLD and IPF. And for IPF, nintedanib is an effective and approved treatment. So we are trying to extrapolate by studying its effect on SSCLD. And even in SSCLD, we got fibroblast in activation, myofibroblast accumulation and deposition of extracellular matrix. In addition, nintedanib targets receptors specific for PDGF and TGF beta, which play a key role in the pathogenesis of SSCILD. So there are currently no drugs approved for the treatment of SSCILD, and with the exception of nintedanib and pirfenidone, which are available for patients with IPF. In fact, there are no drugs licensed for the treatment of progressive fibrosing interstitial lung disease. So the clinical rationale for nintedanib and SSCILDs is that it targets a receptor involved in the pathogenesis of SSCILD. It impacts the fundamental process of lung fibrosis in relevant animal models. The antifibrotic activity of nintedanib is independent of the initial disease trigger, and hence the inhibitory effects of nintedanib on pathological process of lung fibrosis should translate to clinical effects in SSCILD, and I think this would be dealt with by our next speaker, Dr. Sujit Rajan, and I would leave this subject to be carried on by him. And of course, for now, thank you for your patient listening. Thank you very much.
Okay, so thank you very much, Dr. Swarnakar, for such a wonderful presentation and taking us through the holistic approaches in management of IPF. And also thank you very much for setting the context for our next speaker, Dr. Sujit Rajan. So what will be the role of nintedanib in SSCILD? So I'll give you a brief introduction of Dr. Sujit Rajan. So sir is a consultant chest physician at Bhatia Hospital and Bombay Hospital, and he has a vast experience in managing respiratory diseases, more than 2 decades of experience. Sir also have a special interest in management of interstitial lung disease and the other sleep disorders, COPD and asthma. And sir has a vast experience in the clinical trials, which are national and international trials. And he has also published more than 20 research papers with his credit. And that has been shared across the nation and across at the international conferences also. So I would request Dr. Sujit Rajan to take over the forum, sir. And sir is going to speak on management of SSCILD. Over to you, sir.
Good afternoon, everyone, and nice to follow my dear colleague Rajesh Swarnkar after this talk on management of IPF. This talk is going to be about, my name is Sujit Rajan, respiratory physician at Bombay Hospital and Bhatia Hospital in Mumbai, and I'm going to spend the next 20 minutes with you on the management of systemic sclerosis ILD. And for all you chest physicians there, I'm going to tell you why this rheumatological condition is important to understand for us moving forward. Systemic sclerosis per se, as a rheumatological disease, consists of Raynaud's phenomenon, skin thickening, fingertip lesions, telangiectasia, gastroesophageal reflux disease, and a vasculopathy. So these are the 6 cardinal features of systemic sclerosis. And why, as respiratory physicians, should we worry about systemic sclerosis? Is 3 or 4 reasons. One is these patients develop pulmonary hypertension, and this has to be treated just like you would treat IPAH, or idiopathic pulmonary hypertension, with all the PAH therapies we have. And so it is generating a lot of interest, not just among rheumatologists, but among respiratory physicians. Pulmonary hypertension and renal failure, interstitial lung disease, and reflux, these are all factors that can make systemic sclerosis much worse than it would otherwise be. And so these are 4 things we need to watch out for. And remember, as respiratory physicians, we are going to see the first and the second one very often. in clinical practice, especially if we liaise with our rheumatology colleagues. IPF, which is a common interstitial lung disease, is often confused sometimes, and there are clear differentiating features. These are younger patients with systemic sclerosis. They're females more than males, unlike IPF, which has a male preponderance. Unlike IPF, which is restricted to the lung, this is a multi-system disease involving the skin, sometimes the joints, the renal system, the GI tract, and of course the lung. Autoimmune serology is also positive with anti-SCL70 or anti-centromere, anti-RNA polymerase 3 turning in positive. Not in all patients, but in a good number of patients, probably more than 50%. And abnormal nail fold capillaroscopy, which your rheumatology colleagues will be much more well-versed about. So it's different from IPF in these aspects for sure. And why should we worry about ILD with systemic sclerosis? Well, there are certain things that as a chest physician, you must know. Diffuse cutaneous systemic sclerosis is a bad prognostic factor. Any patient who sees you within less than 7 years of diagnosis of systemic sclerosis has a worse prognosis. So if the ILD occurs within 7 years of the Scleroderma diagnosis, that's not good news. The black race in American studies has shown to be having a more adverse outcome. The presence of the anti-SCL70 antibody itself can have a worse outcome. Male patients and any patients with reduced lung function or a disease extent or a fibrosis extent of more than 20% on the CT scan is also an adverse prognostic sign. So these are the signs to look out, which can make your patient progress faster. And how do we monitor these patients with ILD? Well, obviously, symptoms, cough, dyspnea, and their skin thickening. And there is a modified Rodman skin score, which by clinical examination at different sites in the body gives you a score. And that is used as an endpoint in some clinical trials. Crackles in the chest, oxygen saturation, which we all know about today in the COVID era. Lung functions, of course, vital capacity, DLCO, and a 6-minute walk test at least once in 3 to 6 months in any patient with scleroderma ILD. And the CT scan as and when required. Ground glass opacities, non-specific interstitial pneumonia, very common feature. UIP, not a good prognostic sign, but can often be there in scleroderma. And the fibrosis score, if you have a good CT radiologist, he'll give you a fibrosis score. And so in Mumbai, at least where I practice, I have the luxury of excellent CT radiologists, which is one of the reasons I took up an interest in interstitial lung disease, was having a fantastic thoracic radiologist to work with. So as and when needed, you can actually monitor those scores on CT. Let's look at the earliest studies of scleroderma ILD. That was the Scleroderma Lung Study 1, and that was cyclophosphamide versus placebo. Clearly, this was done by Donald Tashkin 15 years ago, and cyclophosphamide improved patients with scleroderma ILD, in contrast to placebo, where only about a quarter of the patients improved, half the patients improved with cyclophosphamide. Less patients worsened. And at 2 years, however, sadly, the patients came back to where they were. So though encouraging for the first year, and this was the only drug being given in the early 2000s, that was all we could offer our patients. Also, SLS1 was done in just one country, the United States of America. So it didn't have a global perspective on scleroderma. There were no minimal criteria for fibrosis scoring on the CT. So fibrosis scoring was still in its infancy. Almost 1/3 of the patients dropped out of the study because of side effects, and the effects waned at 24 months. So the excitement on cyclophosphamide really took a dip after this study. And to really summarize it, 1 year, you had good effects on lung function, dyspnea, thickening of the skin and the quality of life at the end of 1 year. But then these effects are sort of weaned off, and barring the benefit that cyclophosphamide had on dyspnea, most of the effects were no longer apparent at 24 months. And that's what then prompted another study looking at steroids around the same time, low-dose prednisolone, IV cyclophosphamide for 6 months, followed by maintenance azathioprine. But this was not an encouraging study at all, because at 1 year follow-up, there was almost no difference in the FVC, DLCO total. The p-values were insignificant. Come MMF a few years later, and then Ari Fisher, a very close friend who works out of Denver and is a autoimmune lung disease specialist, as he calls himself, and he's really very good in this work, started looking at patients who are on MMF for connective tissue disease, ILD. Retrospective study, 125 subjects with all kinds of CTDs. And then he looked at when MMF was started and where their vital capacity was going. And clearly he could see some improvement, if not at least stabilization. And if you look at this graph, you can clearly see that it's probably a little improvement at the time MMF started. And the effects of MMF have been really fascinating for many years. MMF in acute alveolitis in the lung has been found to be, in clinical experience of respiratory physicians, a superior drug, even for chronic hypersensitivity pneumonitis, as compared to azathioprine. And you can see the median prednisolone dose at MMF initiation was 20 milligrams a day of prednisolone. And 1 year on MMF, almost everyone was on just 5 mg with a p-value very, very significant, regardless of the type of connective tissue disease. So MMF clearly has steroid-sparing effects. And so the gist of MMF in CTD-ILD was very well tolerated, low rate of discontinuation. You could taper corticosteroids well, stabilize lung function, and it was a long-term option other than cyclophosphamide, which was more toxic. It warranted a prospective study, which was SLS2, and that was MMF versus cyclophosphamide, and at 2 years, they found no difference. And so MMF was better tolerated. And so till about 2 or 3 years ago, I'm sure you've seen all our rheumatologists been treating Scleroderma ILD with just mycophenolate mofetil in a dose of about 2 to a maximum of 3 grams in a day. Neither mycophenolate, though, because these trials were not very robustly done, or cyclophosphamide is approved for SSc-ILD. The CT scans were just ground glassing, no fibrosis scoring was done. SLS2 expected a 4% increase in vital capacity with MMF, but no change was seen. And 36 cyclophosphamide and 20 MMF patients prematurely stopped treatment. And the effects peaked at 21 months and then started to wane off a little bit. So it's interesting to know that these drugs, even though they're being used, are not approved for SSc-ILD. And so we'll come to the next and the final part of my talk, which is the interesting part, which is why are we really concerned today? What we are concerned today is about lung fibrosis, and this has been one of the hottest topics in respiratory medicine in the past few years. And a prospective Norwegian study looked at ILD progression in Scleroderma patients, and the mean follow-up time was almost 3 years. And 50% of these Scleroderma patients had an ILD at baseline. And what did we see? In 60% of these patients with fibrosis, more than 10% had a vital capacity more than 70%. So they had almost normal vital capacity, but they had fibrosis more than 10%. So there was poor correlation between lung function and extent of fibrosis, and therefore the CT is so important. And if you looked at those patients with fibrosis on their scans, you would see that even if the FVC was normal, and please read this carefully, normal FVC, more than 80% predicted. If they had fibrosis on their scans, their survival at 5 years was 69% compared to 83% if they didn't have. And their 10-year survival was even lower at 56%. Preserved lung function, a little bit of fibrosis also worsens survival. Okay, and it's an independent risk factor, fibrosis on the scan, for mortality. So you've got to screen these patients early, and that's one key message. In fact, the most important message from my talk, if you have to take home one message. And this was Hoffman-Wald, who did this study, and that really prompted more research. The more the fibrosis, the more the mortality. And if you look at this, if the patient had 25% lung fibrosis compared to no fibrosis at all, that tells you that the standardized mortality rate was 8 versus 2.2 in patients with fibrosis, without any fibrosis. So quantifying the fibrosis is going to be very important, and you've got to push your CT radiologists, all of you, to get that done. Census studied this, and that is really the excitement we have today, because Census was a study done in 32 countries across the world, including India, 5 continents. So we had a heterogeneous population, unlike the early scleroderma lung studies where only the United States of America was studying. So we had a heterogeneous population across the world. And what was the objective? An antifibrotic drug, nintedanib, to be given to patients with scleroderma ILD and look at whether their vital capacity declined less at 52 weeks, which is 1 year. The secondary endpoints were whether there was a change in the modified Rodnan skin score, the skin thickening that you observe, and was there a change from baseline in SGRQ, St. George Respiratory Questionnaire, under health-related quality of life. So what happened in this study? Nintedanib was given from screening to follow up. You can see here 52 weeks was the primary endpoint, and the patients were randomized as to those who had anti-topoisomerase antibody status positive, which is SCL70. For those of you who are not familiar with this antibody, it's the same thing as SCL70. Whether they were positive or negative, to see if there was a difference in their progression. And patients were blinded until the last patient had reached week 52, but for not longer than 100 weeks. And if you had a few adverse events, you could reduce the dose to 100 milligram BID. Patients were aged more than 18 years, and scleroderma diagnosis was based on the 2013 ACR-EULAR criteria. As far as I know, these have been updated in the last couple of years. With disease onset, first non-Raynaud's symptom, less than 7 years from screening. ILD, based on the chest CT, more than 10% extent of fibrosis of the lungs had to be there. And the CT had to be taken less than 12 months from screening and confirmed by central assessment. So it was a central reader so that you had uniformity in that CT reading. FVC had to be more than 40% predicted, and a DLCO more than 30% of predicted at least. So you didn't want very severe oxygen-dependent patients as far as possible. Excluded patients with liver dysfunction, high risk of bleeding, because we know nintedanib can rarely have that side effect, unstable angina on blood thinners and dual antiplatelets, more than 3 digital ulcers or history of severe digital necrosis requiring hospitalization, severe significant pulmonary artery hypertension, or a scleroderma renal crisis were all excluded from this study. And what was permitted was prednisolone, less than 10 milligram per day, or a stable mycophenolate or methotrexate dose for more than 6 months prior to randomization. And dose reductions from nintedanib from 150 to 100 twice a day, and treatment interruptions were permitted to manage adverse events. The treatment medications which were not allowed were prednisolone more than 10 milligrams in a day, 8 weeks prior randomization, azathioprine, HCQ, colchicine, and 6 months prior randomization, cyclophosphamide, rituximab, tocilizumab, abatacept, leflunomide, tacrolimus in the 6 months before randomization. These were the baseline characteristics of the patients. So about 60% of the patients were anti-SCL70 positive. About 50% of patients were taking mycophenolate. So you should know the background. And the extent of fibrosis was about 22% on the CT. The FVC percentage predicted about 72% in the nintedanib arm. So very comparable, both the arms, nintedanib and placebo. DLCO above 50% in both arms. And as you can see here, these three things are very important to take into note as we come to the results. And the census was path-breaking in that the difference between nintedanib and placebo was a good 40 ml. And with a relative reduction of 44% with nintedanib versus placebo, p-value 0.035. Now, is this meaningful, you would ask, 40 ml? Well, it is, because this disease starts at middle age. Those small annual declines that we are able to arrest and slow are going to accumulate over several years. An FVC decline is associated with mortality. We know that. And this has been proven in multiple studies. So this treatment effect for sure is meaningful. And so the first ever time you had an antifibrotic triple kinase inhibitor that showed such a treatment effect. Primary endpoint was significant. As you can see, the graph separating probably a little after 12 weeks here and a good separation at 52 weeks. You can see the much higher slope in the placebo arm. Post hoc responder analysis for decline in FVC. So if you look at the decline in FVC less than 5% in nintedanib versus placebo, you can see 67% versus 56%. So you had much more patients who were declining, who had declining less and had an improvement. And so these patients were much more compared to placebo. Also, if you look at extensive versus limited interstitial lung disease, FVC more than 70 would be limited, FVC less than 70 extensive. Clearly, there was a reduction in the FVC decline in both these subgroups, whether they had extensive ILD or they had limited ILD. So this is also very clear. So it doesn't have a better effect on limited versus extensive. Side effects very similar to the Impulses trial, which was nintedanib in IPF. And you can see here very clearly diarrhea predominates, nausea and vomiting follow. And the intensity of the diarrhea, however, was never so bad that you had to really get off the drug, at the most cut back to 100 milligram twice a day. 82% of patients reported 3 or less than 3 events, but 95% of that diarrhea you saw in the study was manageable with loperamide or dose-modifying strategies. And it was similar whether the patient was on nintedanib with mycophenolate or not on mycophenolate. So to conclude, the census trial reduced ILD, nintedanib reduced ILD progression in patients with SSc-ILD with a significantly lower rate of decline in FVC over 50 weeks versus placebo. And it reduced FVC decline in all patient subgroups, irrespective of age, sex, anti-SCL70 status, baseline fibrosis, or duration of disease. There was no effect, however, on the secondary endpoints, which was the MRSS or the SGRQ scores, and the adverse event profile was identical to that of Impulses, with diarrhea being pretty well tolerated with dose reductions or antidiarrheal agents. The question that is interesting, and I'm sure I will get asked, is should MMF continue? And though we saw this approximately 40 ml difference between nintedanib and placebo, if you did a subgroup analysis, which I was discussing with Kevin Flaherty, who's the principal investigator of InBuild, is that the drop in patients who were on MMF was 40 ml, but if you looked at the patients who were not on MMF, then they declined a little more. These values are small. They're not very significant, but they do make you wonder whether you should continue the background MMF when you start nintedanib. And I see many rheumatologists keeping the mycophenolate on and adding on the nintedanib, monitoring liver functions very closely. A little bit about non-pharmacological therapy in scleroderma, ILD. Don't forget about pulmonary rehab. Very important for all of you. Don't get excited about drugs. I think we're living in an era where every few days some new drug comes up for COVID and people just seem to want to rush onto the bandwagon. Little realizing that sometimes doing nothing for the patient is probably all the patient needs. It applies to any disease where you know you don't have dramatic cures. Scleroderma, ILD, no exception. Rehab goes a long way. Trust me, give any drug to a patient, add on rehab, and you will see the patient feeling better, doing more, and in general, feeling much happier. Oxygen at rest in patients who are hypoxic and on mobilization or rehab in those who desaturate on exercise, worth considering. Appropriate management of GERD, we know if these patients reflux more, they're going to aspirate more and they're going to have more lung damage. So please manage that well. Vaccinate them with pneumococcal, preferably the conjugate vaccine or the polysaccharide vaccine, an annual quadrivalent influenza vaccine. And we hope next year that becomes a pentavalent influenza vaccine. Supportive and palliative care goes without saying. That's extremely important because if you can't cure, you want to treat their symptoms and help them through their symptoms. And we have a palliative care consultant for all our advanced disease patients with lung fibrosis and refer them for transplant early. So to conclude, my take-home messages are that chest physicians need to understand scleroderma better. We're going to see many more and be involved in the management of many more of these patients. CT imaging is going to be key, not just a CT scan, but a good quality scan, which is reported well. So you have to have a good CT radiology buddy. Without that, you can't practice diffuse lung disease as a subspecialty very easily. Coordinate well with your rheumatologist because he's vital to the management. MMF still has its place, in my opinion, so too pulmonary artery hypertension therapies. And finally, as we discussed today, nintedanib has a very important role in slowing disease progression after the census trial results were published last year. Thank you so much for your attention and to the Indian Chest Society and BI for supporting this webinar. And I'd be happy to take questions during the panel discussion. Good afternoon.
Just wait. So, as we have heard Dr. Sujit Rajan before also, so extremely excellent talk, sir. So, and I'm extremely thankful for you to take us through the different therapies which have been tried in the management of SSc-ILD and the recent trial, that is the census trial, role of nintedanib in SSc-ILD, and what was the endpoints and what were the outcomes of this trial. So now with this, I would request Dr. Prabhu Desai. He is already sharing the screen. So I'll just give a brief introduction for Dr. Prabhu Desai, who is also a third and the most eminent speaker for our today's webinar. So Dr. Prabhu Desai is a senior chest consultant at Lilavati Hospital, and he is also practicing in respiratory medicine since more than 20 years, that is more than 2 decades. And he has also a vast experience in different clinical trials, and he has published more than 34 papers in different national and international journals and also in the different respiratory textbooks. Sir is also a DNB teacher at Lilavati Hospitals. So with this, sir has also a special interest in management of ILD, and beyond that, I would just like to highlight sir has a extremely extremely interested in pulmonary rehabilitation since long. So he has also started a pulmonary rehab center in Goregaon with the name Pratibha Prabhakar Rehabilitation Center. So, as we know Dr. Prabhu Desai very well, so with this, I would request Dr. Prabhu Desai to take over the forum, sir. And sir is going to share his experience and what will be the role of pulmonary rehabilitation in interstitial lung disease. Over to you, sir.
Thank you, Pankaj. At the onset, I'm thankful to you for giving me opportunity to talk on this topic. Um, in any chronic respiratory diseases, okay, rehabilitation is a core aspect in management. And you see, we are all know that COPD, ILD, bronchiectasis, lung cancer, sarcoidosis, these are all diseases which are very important part is pulmonary rehabilitation. In ILD, where today we are going to talk, it's a variable disease, and its treatment also you see that it's variable. You have steroids, then anti-inflammatory drugs and antifibrotic drugs, but there is no drug which is available to really improve the symptoms of the patient and the quality of life. If you see the definition of pulmonary rehabilitation, if you understand the definition, entire importance of rehabilitation will come to know in chronic respiratory diseases, including ILD. I will read the definition because it's important to understand the meaning of the pulmonary rehabilitation. Pulmonary rehabilitation is evidence-based and is a multidisciplinary. It's a comprehensive intervention for the patients with chronic lung disorders who are symptomatic and have disability. It's based on thorough patient assessment followed by patient-tailored therapy, which includes but are not limited to just exercise training. It's education and behavioral changes. Is designed to improve the physical and emotional condition of the people with the chronic respiratory disease and to promote the long-term adherence of health-enhancing behavior. So obviously it is individualized and it is just not exercises. That's very important. And we have to improve the patient's overall quality life, and the symptomatic improvement should be there. These are the various interstitial lung disease of known cause and unknown cause, who I have got common symptoms, and their pathophysiology also is more or less common. If you see all these ILDs, okay, there is a decrease in gas exchange, they have sometimes pulmonary hypertension, they may have cardiac dysfunction which may be silent, and these all lead to increased breathlessness, reduced activity, which leads to social isolation, depression, and deconditioning. A lot of drugs which we use like steroids, hypoxia, and inflammation, which is there, systemic inflammation, leads also to a poor nutritional status, and this leads to a peripheral muscle dysfunction, where there is a decrease in the type 1 fibers, decrease in the type 2B fibers, and the glycogen storage of the muscle fiber also reduce, and these muscles are also go into wasting. So these leads to again disability and deconditioning. So this is an important aspect of pathophysiology of chronic diseases, particularly in this ILD. In COPD, you have air trapping, which is additional component, which leads to a mechanical problem of the chest respiration. All these diseases have got common symptoms of breathlessness, fatigue, weakness. They are immunosuppressed, and there's a reduction in the functional capacity of the patient and quality of life. But if you see the effects of pulmonary rehabilitation, there is very little known regarding the effect of PR in ILD. But there is evidence to show that improvement in exercise capacity happens, shortness of breath happens, and quality of life is also improved. There are some other benefits like reduction, which I have observed is reduction in hospitalization, reduction in unscheduled healthcare visits, improved limb muscle strain and endurance, improvement in the functional capacity, activity of daily living, emotional functions improves, and patient understands about his disease and he able to enhance his collaborative self-management. So this is the all benefits of rehabilitation. In ILD, you have got a lot of grade A evidence in COPD rehabilitation and the benefits. But that much evidence in ILD is lacking because of very less trials being done. If you see the Cochrane review in COPD, there are many studies, many randomized controlled papers are there. which shows that rehabilitation forms an important component of management of COPD. Improvement is not just mild, but moderately large and clinically significant. What about Cochrane meta-analysis in ILD? To determine whether the rehabilitation in patients with ILD has beneficial effect on exercise capacity and symptoms with quality life and survival compared with no rehabilitation in patient with ILD. To assess the safety of rehabilitation in PFT in the ILD, the Cochrane meta-analysis was done. And they have selected 5 studies which are included in this study, which shows that no adverse effect of pulmonary rehabilitation was observed. It's very important. And rehabilitation improves 6 minutes walk test, improves oxygen consumption, and not only in just ILDs, but in idiopathic pulmonary fibrosis, particularly amongst ILD, who has got a worse prognosis. In this group of patients also, there is an improvement in walk distance, oxygen consumption, VO2 max, and reduction in dyspnea and improved quality of life. Interestingly, the pulmonary rehabilitation is also associated with decrease in anxiety and depression. Okay. When there is a exercise tolerance and quality life also improves. We have also done a study in 100 patients published in JAPI that it shows that significant benefits were observed in 6 minutes walk test distance, muscle strength, dyspnea, and quality of life. And this difference was very obvious, especially in the muscle strength. All group of muscle strength was improved, and the quality of life also was better in post-pulmonary rehabilitation. And also here you can see the difference in the pre and post CRDQ score and 6 minutes walk test distance. It is important to know that this benefit is not just seen in mild moderate patient, but it is seen in severe ILDs also. So even in severe ILD, there is a role of pulmonary rehabilitation. When you refer the patient for rehabilitation, there are some exclusion criteria, and we must know that patients with severe orthopedic and neurological psychiatric problems have limitation. You can't refer them for rehab program. Pulmonary hypertension, syncopes, which happens during exercise, and unstable angina are some of the exclusion criteria for referring this patient for rehabilitation. The goal is very clear of rehabilitation center, that to improve the shortness of breath, improve the ability of daily living activities, and improve the quality of life. We are not going to discuss how to set a rehab center, but it is very important to know that the rehabilitation center and the activities will depend upon the country to country. It will differ. It will also differ state by state and even the center by center. The reason is that all depend upon the structure and all depend upon the policy and healthcare needs of the place where you are doing the rehabilitation center. Now, currently we see that because of lockdown, we still continued our rehab program, but they are all web-based rehab program. It was very successful and very effective. So we have to modify the rehab centers and rehabilitation activities as per the place and as per the facilities. Very important to know that components, though we are not going to do the structure of rehab program and rehabilitation center, education is extremely important, and education is given by the physician, is also given by the physiotherapist during the rehab program when you are doing in-person rehabilitation. Education is about the disease, the available medicines, oxygen therapy, and other aspects of the disease. There is a general exercise training, which is a core part of rehabilitation. Even in ILD, this is very important that the exercises to be continued to improve the muscle strength. And even with this disease, ILD, this is continued along with the oxygen therapy. Whenever the patient has got chronic disease, the nutritional needs are more. Especially, we have to have a nutritionist in the rehab program, because when many patients are malnourished and they have to be given adequate protein, fat, and carbohydrate to these patients. Micronutrients, vitamins have a role to play. It is also important to understand about the hydration, the electrolytes which we are giving to this patient, salt, all those are very important. Fibers in the diet, so that they have lesser abdominal bloating. So nutritionists play a very important role in the rehab program. Psychological support is needed to all these patients. Generally, it is taken care by physiotherapists, respiratory therapists every day whenever they come for the program, and they're the best psychologists for the patient. But in case sometime you need a special attention and you need a counselor, very rarely we require a psychiatrist. Breathing training, retraining is very important. In COPD, you are well aware about diaphragmatic breathing and pulse sleep. But even in the ILD, the breathing relaxation is very important when they are breathless. And even we have found that yoga pranayam has got a great role to play in relaxation and improving the breathing. All these patients' outcome assessment is very important to document whether there is a stability in the disease conditioning, whether there is a deterioration or there is an improvement. And we always give them a booster program after assessing the patient. And this assessment is done both by obtaining their 6 minutes walk test, their muscle strain, and others St. George questionnaire based to find out quality of life. Well, any rehabilitation center or any rehab to be successful, whether it's COPD, ILD, you need a team, okay? And the team consists of respiratory physician, physiotherapist, nurse, nutritionist, occupational therapist, social work, and coordinator is very important, who can coordinate everything from references to the outcome of the patient and giving the patient back to the physicians regarding managing their medical aspects. And so this is a whole entire team look after the rehab program. As well as particularly ILD is concerned, patient selection is concerned, we select all the patients of all different types of ILD because the benefits are good in all these ILDs. Maybe variability is there in the, as well as the benefits are concerned, but it is there in all groups of patients. So we select all the patients. We individualize, assess the patient. The assessment is done by the physician as well as by the respiratory therapist. And that includes symptom assessment, comorbidity assessment, other system, how much is the cardiac and the musculoskeletal system is involved. All those things are assessed. Then we always look for the lung function, cardiogram, QD echo, 6 minutes walk test distance, and other, if other things are required, like CPT is required, or your shuttle watch take is, you suppose you are doing that, you can do it. And this is called individual assessment of the patient. The selection of type of program is also decided by the physiotherapist, whether they would like to do a home-based, hospital-based, clinic-based, or whether it's a web-based program. Program composition, I'm not going to go into the depth of it. It is a core subject of respiratory therapists who will decide what exactly programs that patient should be given after thorough assessment and understanding the patient's need. Reassessment and follow-up is very important, and it is very important to see that the patient remain adherent to the program, and he's shown there's an improvement happening to them by documentation. That's very important. The patient is very happy after documentation is done and show that what level of improvement has happened after rehab program, after the rehabilitation. There is something called non-exercise component of rehabilitation, which include education, which include the patient's end of life or care of the patient. If there is a pre-transplant, post-transplant care, and obviously in this group of patients, we also have a core knowledge about giving about the oxygen therapy and group discussion, etc. and all that. So this is called non-exercise component. It is very important to know that the National Institute of Clinical Excellence reports that the patient with IPF is, in IPF, it is cost effective to offer a repeat PR programs over 6 to 12 months. Because the benefit of the rehab program in the interstitial lung disease doesn't last more than 6 months because of the disease progression. So repeat programs are really important to them, and they should be repeated every 6 months. As well as the COVID part is concerned, I'm not going to go into the detail, but remember, pulmonary fibrosis is one component of COVID-19. There are many other components like physical impairment, cognitive impairment, swallowing impairment, psychosocial support. And when you consider for rehabilitation, it is not just for the fibrosis to improve the oxygenation of the patient, but or improve the 6 minutes walk test distance of the patient, but overall improvement should happen in the patient. And in this rehabilitation, I am happy to say that we have got a huge experience. Up till now, we have got 50 patients who are enrolled and they are ongoing rehab program for COVID-19 sequelae, and they are doing extremely well. And what we realized over here is that the yoga, pranayam, and meditation can become a core part of a rehab therapy in this group of patients. Okay, because large number of this patient has got a cognitive and psychological problems. We also realized that web-based program is very good program. Before the lockdown, we were doing almost 30 to 35 patients a day. During the lockdown, we never stopped our rehab, but we shifted to web-based program. We have almost 6 to 7 physiotherapies. Some of them are doing the program from Germany and Canada, and they are also helping us to organize the load. So we realized that there are some issues about the connectivity, but still web-based program can be a very good program, not only for COVID, but some of the patients who are having difficulty in coming to the center for in-person rehabilitation. I'm not going to again depth of it, but it is always in COVID rehabilitation is individualized and it is always monitored. And there are lots of benefits they get after the rehab program. So summarizing my talk, pulmonary rehabilitation is an essential component of ILD management. Just like you have anti-inflammatory drug and antifibrotics, hypoxia and muscle wasting are the limiting factors in all ILD. All the forms of ILD show benefit with PR, which may vary in magnitude. Exercise training is a core component of pulmonary rehabilitation, and it is very important that as a chest physician's role to make the patient adherent and in continuation of the program should be, and they should continue the program, and that should be stressed on. Thank you.
Thank you very much, Dr. Prabhu Desai, sir. It's always a pleasure to hear you. And today it was a kind of a very different topics which you have talked upon, and you have shared your opinion on the pulmonary rehabilitation. So you have a vast experience of pulmonary rehabilitation. So it's good to know that pulmonary rehabilitation is not restricted to the interstitial lung disease only. It might help to the other respiratory diseases as well. So thank you very much, sir. And I would request Dr. Rajesh Swarnakar to take over the forum, and we will have a Q&A session with all the speakers now. And I would request all the panelists who have joined this meeting, if they have any question, they can put the questions in the Q&A box. Over to you, sir. Swarnakar, sir.
Yeah, thank you, Pankaj. And again, welcome Dr. Sujit and also Dr. Prabhu Desai. We had a very interesting session, in fact, and we'll start the Q&A session. So the one question that is asked in such webinar always is to which of the drug to use in IPF and SSc-ILD. Whether we can initiate basically nintedanib, or of course we have to start with pirferidone. And my take is always that basically between the two, if we just leave the cost, then I think pirferidone has got basically a safety profile issue, in fact, and with nintedanib. And in a pirferidone, we have to basically go for titration of doses. So if you suppose you want to go to the highest dose, you can't start it straight away, but you have to just slowly just build up the dose, which is not so in case of nintedanib. And also acute exacerbation data is also lacking with actually pirferidone, which is there with nintedanib. So I would start my basic question answer session by asking the same question to my also able panelists, Dr. Sujit and Dr. Prabhu Desai, that in next practice, what would you do if you've got a patient of SSc-ILD and IPF, which drug would you, which you're going to prefer? Dr. Sujit first.
So Rajesh, with scleroderma, ILD, I don't think there's
Got any other drug?
much doubt that we would prefer to use nintedanib right now. The evidence is significantly in favor of nintedanib, though there are trials with pirfenidone. I would say after census, I would be compelled to use nintedanib in SSC ILD. As far as IPF is concerned, it's becoming a difficult choice now because cost apart, both the drugs are effective, though there is a slight advantage to nintedanib in terms of prevention of acute exacerbations. And we know that one of the single most biggest risk factors for progression of IPF is an AE. So any patient with an AE has an almost 10 times higher risk of progressing than someone who doesn't have an AE. And so probably there would be a tilt of balance there towards nintedanib. Also, a conversation with the patient, which I always mention, Rajesh, is important because there are some patients who have bad gastroesophageal reflux, hyperacidity. They probably wouldn't be good candidates for pirfenidone. And if diarrhea is an issue that they already have, it's going to get worse with nintedanib. So that conversation is important. Skin rash that you get with pirfenidone and oral anticoagulant concomitant use with nintedanib is a bit of a concern, though we have heard that patients who have been using oral anticoagulants with nintedanib post-COVID have had no bleeding tendencies. So that's good news. But I think it always will boil down to a conversation with the patient, considering that both drugs are almost equally priced now.
Right. So I think by the tolerability is an issue. So
That's right.
Of course we can choose either of them, but of tolerability and safety profile and other data that we have, that will be a criteria quite considered to choose which drug you use. What opinion, Dr. Prabhudesai?
Yeah, I agree with Sujit about nintedanib being the first choice in ILD scleroderma. And obviously, the reflux issue, which is very common with pirfenidone, okay, that also makes you difficult to use in scleroderma ILD because they have already the esophageal issues. Well, as well as other ILDs are concerned, because of the, as you rightly pointed out, you have got a 600 milligram, 800 milligram pirfenidone available. And I have noticed that the side effects which with the single tablet or 3 times a day is much lesser compared to the multiple tablets that patient takes. That is my observation, and I find that probably the pill burden was mainly a psychological issues among the patient about the side effect of pirfenidone. They tolerated very well in post-COVID fibrosis. Also, the tolerance of full dose of pirfenidone for more than a month is they are without any really side effects. Neither liver enzymes were elevated in significant number. Neither they have any upper GI problem. We have even seen the weight gain happening with the exercise and nutrition and the pirfenidone. So it's a difficult choice. And as Sujit rightly pointed out, finally we have to discuss with the patient. The skin manifestation will decide which should be the drug. Liver should be whether we should shift from pirfenidone to the nintedanib. Now they have got a choice. Okay, even if you start pirfenidone, some of these patients will go on nintedanib very easily, and people who have got nintedanib issues, we can try a pirfenidone on. So I think we have to. It's a complementary, you can say, unless somebody comes that the combination is useful or more useful, then probably we may have to try a combination therapy. But if the trial is there.
Yeah, I agree, Rajesh. Probably we're one of the few countries that have the luxury of easily using the combination, and there's no restriction.
No restriction.
Its use. So we should be getting data from India on combining 2 antifibrotics earlier than any other country in the world, where I think no insurance company is going to pay for both antifibrotics worldwide.
But also, Sujit, there are actually trials have been conducted, in fact, outside. If you see the trial, sites, and you just type both the drugs, you would find
Yes.
So there are a few trials, in fact, 2 or 3 trials which have done. Some of them have also concluded. And the issue was there about tolerability. So when you combine both the drugs, I think the side effects that you get out of it are quite important. And in one other study it was there for about 40% of the patients.
Right.
So in fact, after that, I don't think any study which is going on, and even these studies were quite few, who they just recruited about 57 to 102 patients in 2-3 studies. So I think the problem with combining, as it came out from those study, and of course we'll have to do a large scale study, and as you said, that India would be, I think probably be the enough best advantageous stage to do that. Another actually questions that is being done, and another way to catch up with I think other countries is about multi MDD teams which are there. So what is its importance? So of course we know that it actually leads to higher confidence in also making the diagnosis in ILD. It leads to improved also prognosis, and integrated management also lead to basically clearing your doubts about diagnosis. And MDD should include clinician, pulmonary physician, radiologist, and also pathologists. So what are your views? I mean in fact, do we have enough MDTs in India, or it's time to really basically start that by just making the awareness? Dr. Sujit?
So Prahlad and I were actually doing MDDs online about 6 months before the lockdown. And it's interesting because at that time, Prahlad and I it was probably the first time we heard the word Zoom, Rajesh. And our CT radiologist introduced us to that term. And we said, my goodness, what is this Zoom? And we would have never believed that we would have done so many Zoom meetings after that from March onwards. But I think online MDDs are here to stay. It's a phenomenal way to do an MDD. I cannot see, in fact, I don't see in-person MDDs happening very often, because what is there to show in an MDD? You have your online imaging, you have online pathology, and you have a conversation between about half a dozen people or a little more. So to me, an MDD should only happen online. I don't know what Prahlad's thought on it is.
Yeah, true.
Yeah, Sujit, I agree with you, but there are certain things which are a little against that. The timings of MDD is something which is has a problem, because all these consultants are busy in different part of the their work, and so that the common timing is very we have to come to that. Then those people who are having MDT should have one common interest, is diffuse lung disease. Okay, so that is also an important thing. And CT radiologist also should be very freely available for that particular time. His interest also should be the respiratory medicine and not multiple things.
Sure.
Then only it will can happen. Otherwise, not everybody can join all. But you are rightly said, if you have a group of doctors with a common interest, if 10-15 doctors are together, not everybody will be there in each meeting, but say at least out of 10, 5 or 6 meetings, one person can attend, and his contribution will be great. The most important person over here is the radiologist, okay, who has to coordinate the meeting, and because he is going to the key person to discuss the radiology, CT radiology.
So I think now that we have that online platform, and we are quite well versed with it because of the pandemic. I think this thing, of course, can be an excellent platform, and basically we can have a regional MDD team. So Indian Chest Society is actually working on that with the people just appointing a regional MDD, or it can also be like a district-wise MDD, something like that, in which people can submit the cases and can also get benefit out of it. So I think that would be, can that be a way also forward, Sujit, is to have a regional MDD or MDD at the local regional level where people can submit the cases, and maybe we can have appointment of 4 of this, which will also radiologist, pulmonologist.
I think it's a good idea, Rajesh, but it will hinge on the availability and the quality of the lung CT radiologist. So it will be better than nothing, but I'm assuming respiratory care physicians in smaller towns wanting to get their cases discussed. Now, for them to get their cases discussed, they'll need a really good CT radiologist. And the best CT radiologists are so hard-pressed for time that they will not be able to factor in that time easily across the region, I feel. This is my view on it. They will really have to be, you'll have to have younger CT radiologists that they train to help smaller teams in the region, and then have a major MDD maybe in a metropolitan city, at least maybe one or two in a metropolitan city. Because I can't see it. I mean, Prahlad, what do you feel? I mean, a small city like, say, Ratnagiri wants to do an MDD in Maharashtra.
No, so it will be like people can submit their cases beforehand. So it can be regional MDDs, maybe, which will encompass some region. And then you can pick up those cases and you can submit them to, so
Dr. Rajesh and Dr. Ajit,
Yeah.
The major important factor is the quality of CT scan.
That is true. That's true.
Second thing is that even there should be a meeting with all the CT radiologists, and they should have the changes they should make about the HRCT, the algorithms, what really required. And there should be a common thing should be at least there. The quality of CT should be really good. Then otherwise, every time an expert radiologist will tell you the repeat CT scan is required.
Correct. So Rajesh, I couldn't agree more with Prahlad. Even now, as of today, October 18th, I am getting scans which don't have a DVD.
Correct.
In Mumbai city. Now, if I need a second opinion, we rung up the center 1 month ago, no data erased. If that's going to be the quality of CT radiology, we're going to have a real problem looking at soft copy data and, discussing good imaging. So that needs uniformity. I think somewhere there has to be uniformity in quality of the scan and soft copy availability.
Sujit, I have learned in this COVID time that a small video of a CT scan, which is sent on the WhatsApp or the Google, is really enough. Good. It's really enough.
It's good. It's very good.
I don't know what Bhavin will say if you send a video on the WhatsApp.
Better than a film. Better than a film. For sure.
I think that should be the regular habit of a city people, that send a short video of the city, and rather than depend upon the DVD, because DVD many times has a lot of issues. It takes a lot of time to open, and it is for us in the clinic to open the DVD is a hell of a time.
Yeah. Okay. I think the advantage of the DVD, Prahlad, is that soft tissue imaging, pulmonary arteries, sagittal coronal views, you get everything on that. So I guess a very good CT radiologist would want all the data, but the video of the CT is far superior to the films. There's no question about it. No question about it.
So I think we need to adopt to the new technologies that are available because of the pandemic. And I think there's a way forward for this regional MDDs, which would be a start in a way. And then, of course, we'll learn from that.
Yes.
And then maybe we can, of course, go ahead. So there is another question that I can see in the chat for you, Dr. Sujit, that how frequently do you think systemic sclerosis patients should be screened for ILD, and how would you like to screen them by doing which test? Like, would you like to go for a frequent HRCTs, DLCOs, PFT, 6-minute walk test? So how, because now that we know that ILD is their systemic sclerosis, when to really screen for that? Because sometimes they would come first to rheumatologist and you may not be aware of it, that we have to look for ILD in those patients.
Sure. So about 9% to 10% of all ILDs are SSC ILD, Rajesh. So it's not uncommon. That's a large number. And so therefore, if you have to suspect an ILD, I think rheumatologists should know about screening X-rays at least and pulmonary function. These two things are important. Screening CT scans, maybe not. If the lung function spirometry is normal DLCO, no drop in saturation, X-ray normal, I think you could repeat a lung function once a year, maximum twice a year. So lung function monitoring is probably the best way to pick up an early ILD. And if you do pick up an ILD if the lung function, the DLCO is reduced, definitely get a CT scan done or do an echo to rule out pulmonary hypertension, and then serially monitor on lung function to decide when you do your next CT scan. Definitely not frequent CT scans.
And so also when do you start and antifibrotics in this patient? So which would be the criteria you would use among all these that you have said?
Yeah.
Which you would try to start nintedanib in them?
I think anyone with more than 10%, I mean, there's no guideline for this, but I think it will be dependent on how much the fibrosis score is, because mortality is related to the fibrosis score. So any fibrosis score, according to me, more than 10% would be an indication to consider starting. I see a lot of rheumatologists now warming up to the idea. They weren't earlier, but there are a lot of rheumatologists who are not aware of this also. So it's important that we talk to the rheumatologists who are not aware and who are lagging behind a little bit on this, to teach them a little bit about basics in spirometry DLCO so that their threshold to get a lung function done is a little lower, and then discuss it with them moving forward, because the mycophenolate is still the question mark. Should you continue the mycophenolate or not? Pulmonary hypertension management, also sometimes the rheumatologist is not very familiar, sometimes they are familiar. But there's a lot of advantage I think the patient will get if the rheumatologist and respiratory physician are talking to each other.
And I think including a rheumatologist in the MDD would be another added benefit, so that they can see the cases and they can be made aware that these things do happen.
Absolutely. I think if there's any CTD ILD case in the MD, the rheumatologist should be brought in. Absolutely.
And there's another basically wave, because can we extrapolate basically findings of Impulse's trial in which nintedanib was actually given also in the normal FVC patients, which has got advantage. So I mean, can extrapolate that finding to SSC ILD?
Absolutely.
What's the data there? Because here in nintedanib we say we should not wait for actually patient to worsen, and even if it is, if it's ILD, if it's IPF, and if it's also normal FVC, then also basically you can start nintedanib. There's no need to wait and watch policy, which is there with all of us. So
totally.
So that's extrapolate this to SSC ILD.
Yes.
Do you have enough data for that in census or something?
Absolutely, absolutely. I think FVC can be normal, and that's why, Rajesh, we may have to educate the rheumatologists on DLCO as well.
Correct.
So spirometry with DLCO, because in a normal FVC, in an ILD, the DLCO will be below 80%. And you can't see a bad ILD with a DLCO more than 80%. More than 80%, you'll probably want to wait and watch actually for any ILD to treat. Unless your DLCO is say 105%, which we have seen, dropping to 95%, 87%, that's also a falling DLCO. So DLCO education and spirometry to the rheumatologist is important, so that their threshold to refer or to understand lung function better is less. And that advantage is there, because even though it's a 40 ml reduction versus placebo, it may not sound much because it was much more in pulses.
And every year.
Yeah.
It's every year this thing.
Every year. So it's accumulate. Yeah, it accumulates. Every year, 40 ml is going to slow down reduction in lung function and reduce mortality. And then hand in hand, you got to also, of course, monitor the pulmonary artery pressures, because those are 3 or 4. It's not just the lung fibrosis, but the pulmonary hypertension. Both can affect mortality. And of course, renal function, which I've rarely seen actually. Scleroderma, renal crisis, I've not seen too much, but I don't know if Prahlad has a thought on that. Largely ILD PAH.
Yeah, so actually we can do that, in fact, and then we can start interviewing those patients who are really having declining DLCO and this thing. Another question that comes to mind in IPF is what are the palliative care that should be initiated apart from, of course, antifibrotics? And as you said, something it should be good if we don't do anything for the patient. It may be helpful in some end, and that's a golden word that you have said today, that basically we can leave it like that and we can just give, rather than starting some treatment and then having a side effect. So what are the palliative care that actually we should focus on apart from vaccination? You have said rehabilitation, oxygen, and how it should be done, in fact, in one setup.
Sure.
I think I would let Dr. Prabhu Desai answer it first and then switching.
Well, I will say that is a, I don't know the word palliative care, but I will say that every patient of chronic respiratory disease should be referred for a role of rehabilitation. Okay, every patient, okay, who has got breathlessness as a main complaint, fatigability, and some sort of an anxiety, depression. All these patients will definitely benefit from pulmonary rehabilitation. And what we learn in this COVID, that rehabilitation will be uplifted by very, very high level, because a lot of patients are now referred for a web rehabilitation, COVID fibrosis patient and COVID related complications. So rehabilitation will come as a part of the therapy in all the, not only medicine, respiratory medicine, but even the other branches of medicine. Okay, so all these patients should be referred for a rehabilitation. And when you refer the patient for rehabilitation, all these aspects will come. That is aspect about the education about the disease. The most important thing is about the using their oxygen therapy correctly. Then third is how to take care of a seriously ill sick patient at end of life care, what we call. Okay, whether they are really to be considered for unnecessary hospitalization, etc. and all that. That is very important aspect. Nobody else than Sujit will explain to this very well. Then pre-transplant, because transplants are going to happen and we should have a pre-transplant care, rehab, and if the patient comes falling after the transplant, suppose in future I'm talking about, you will require, then you must have to give them post-transplant rehab care. So this is all will come into that as a palliative care, and this will be a branch itself, according to me. Okay.
Yeah, I would add to that I think as respiratory physicians, we will never have enough palliative care physicians to really support us. You know, with great difficulty, we have literally one or two non-cancer palliative care physicians in the whole city of Mumbai. So if we rely on just one or two, we won't be able to function. And as Prahlad rightly said, we'll have to take on the job ourselves. The word palliative itself takes patients aback, and they feel that this is all to do with end of life, and that's a big mistake that of patient perception and even physician perception. And I've had this discussion with colleagues in the United States also, who believe that palliative care is about end of life care, and this is so completely wrong, Rajesh. Palliative care is about symptom care. It just teaches us how to look at patients with a different set of eyes. We are so focused on making a good diagnosis in chest medicine. We are focused on ordering the right tests and putting down a prescription, that we forget that the patient's priorities or patient's problems are sometimes completely different from what we are writing down. And the patient has financial issues, or the patient has social, marital issues, which we have not even gone into the details. Whenever I refer, just to give you an example, whenever I refer a patient to my palliative care physician, non-cancer, she will come out with history of the patient that even though I've known the patient for a couple of years, I've never taken. And I think that is the difference. That's something we miss, you know, and she'll tell me, look, you forgot about this, and that's why this patient is suffering so much. Whether it's a mental issue, a physical, emotional, spiritual issue, it's just amazing how that small change in the management can make such a huge difference to outcomes and patient satisfaction with the physician. And I guess that's what all of us physicians are trained to do, to be good physicians and care for our patients. But we sometimes, I tend to feel, and Prahlad will agree, that in the busy schedules we have in the hospital and outpatients, we sometimes forget what the patient's actual problem was when he entered the clinic, in contrast to what we actually are offering him. You know? So it's just that, you know, to look at the patient with a different set of eyes, symptoms, focus on symptoms, and a lot of other issues.
True. So I think all the simple measures, like, you know, oxygen, giving oxygen if the respirator falls below 88.
Sure.
If you can refer them for also rehab, also order them also what they call all these vaccinations
Sure.
and all rehabilitation would go actually a long way in also
Absolutely.
elevating his problems because of IPF and not just giving tablets and trying to deal with it like that.
Or for instance, a patient who's on breathless on oxygen, Rajesh, low dose short acting morphine acts beautifully, 2.5 milligrams twice a day, escalating the dose. Many respiratory physicians are not aware of how well it works and how it can be used. So that knowledge and training is very important. I'm very happy that the ICS is taking an initiative on respiratory palliative care training from the end of this year. So you're looking
because you will be
forward.
there, Sujit, and you will be there to also guide us. In fact, because you've got so much work in palliative care, I've been also hearing your talks about this end of the life care and palliative care. I think you would be the person who can lead us in that.
Looking forward to that, Rajesh. Looking forward.
And I think none of the webinars actually can end without a mention of COVID. So there are a lot of questions. In fact, what is the role of antifibrotics in COVID, and of that thing also brings us to another issue that do you think that IPF and other fibrosing lung diseases share also common or mechanism and also pathogenesis so that we can use them in all fibrosing conditions? And a focus to COVID because people would like to know, because you are now having people who are now having got a long haul COVID, and you tell that they've got COVID fibrosis. So, in fact, are we right in starting them? Although of course we are aware that it's an off-label use. But then what have been your experience? Because you have got more experience, because I am from Nagpur, and Nagpur is just seeing the surge. We have just seen the surge. It's declining, and of course we'll be getting these patients. We'll be getting this patient soon. So what have been your experience in these patients who are really stuck with oxygen even after 33, 34 days of their actually first onset of symptom, and still having what you can see, CORAD score of more and having stuff. So what's your idea of starting antifibrotic, or you would wait for some time, let it cool off, and then again assess and then start? What would be a strategy? First Dr. Sujit and then Dr. Prahlad.
So no data in this space, Rajesh. I'd really be interested in knowing what Prahlad has to say here. But from what I've experienced, we have been using both Pirfenidone and nintedanib now. One thing is clear, that patients seem to tolerate Pirfenidone very well. I think COVID there's so much suffering in COVID that the gastric intolerance of Pirfenidone has come down. So we're able to escalate the doses higher. But one very reassuring news for patients is that the 3-month follow-up scans, which I've been seeing in the last couple of months, have shown significant resolution of reticular opacities, traction. And so I don't think we should be very quick to jump to the gun until we have more evidence. However, in patients who are really scared, who are breathless, low DLCOs, I don't see a harm if they can tolerate an antifibrotic to start one, and probably consider stopping it at 6 months or 9 months once you have stabilization of lung function. We know that post-viral infection, ARDS, and lung fibrosis usually doesn't progress. But in some patients, we have seen it progress. It's a minority. So whether to use an antifibrotic should be a careful decision. It shouldn't just be thrown at every patient with lung abnormalities. Which antifibrotic? Currently, I would prefer nintedanib, because for 2 reasons. One is it's just 2 tablets. And the second is that in the Impulses trials, if you look at Impulses versus Capacity and Ascend, the decline in lung function, the graphs between the antifibrotic and placebo, they separated in 2 to 3 weeks itself with nintedanib, whereas it took almost 12 weeks for Pirfenidone to have a treatment effect. So, and nintedanib has some benefit in preventing acute exacerbation. So probably nintedanib over Pirfenidone, but I don't think anyone really knows the answer to this question.
So I think it would be worthwhile to wait for maybe 4 to 6 weeks and see if suppose he improves just by some rehabilitation exercise.
Yes.
Doing some antithrombotic, maybe with low dose steroids for a longer period of time than we give usually. What about you, Dr. Prabhu, say?
Well, again, this is just observation. It is not something that we have studied. But I have seen patients who are coming from government hospitals and for follow-ups, and they have really not taken any antifibrotic, and we see there is a good improvement in the HRCTs. Okay, it takes time, but there is an improvement happening. Very difficult to say because the most of the HRCTs are consolidations, organized pneumonia pattern, and very less traction bronchiectasis is seen. Okay, so obviously a large number of patients which are hypoxic and take long time because their inflammation takes longer time to respond. I can say it doesn't mean that the fibrosis is happening in them, and even the fibrosis suppose happens. Okay, it is not like an idiopathic pulmonary fibrosis or you can say that chronic hypersensitive pneumonia fibrosis where there is honeycombing which is in very few patients, but we don't know their previous scans where how they were. But a lot of cyst formations, a lot of bronchiectasis have been seen as a sequelae of COVID fibrosis. So not everywhere there's a fibrosis. There are a lot of patients have got air trapping also. The large number of patients also have got cyst formation in the lung. So whether putting nintedanib or antifibrotic early has got any role to play, I don't know. But there is a tendency, if you don't put, somebody else will put. Okay, that's very important to know. Okay, because there is nothing else left for the patient who are hypoxic and who require high flow oxygen and who are in the hospital for more than 3 weeks. Okay, so I feeling is that we are very lucky that we are in India practicing and we have drugs which are available. So why not, we use these drugs judicially and at correct timing. So not at the day one we should start antifibrotic, but yes, at the day 3, day 4 weeks, suppose if the scan shows that there's a traction bronchiectasis or septal thickening like that, or crazy paving appearance at some area which is persistent, we can start antifibrotic, do observe, but we don't know duration of how much we should give. Dosages which we know, but duration we don't know. But we observe this patient for say around couple of months, and at least we'll know that whether patient tolerate that much dose or not. So we'll learn from those experience. We'll learn also from our experience that how the antifibrotics, whether starting is going to be useful in this patient. I think the data should come from the radiologist more than a chest physician, because the radiologist will have a large number of CT scan of the same patient, on follow-up. So even if they ask 2-3 questions to the patient, what medicines you have taken up till now, okay, that is sufficient. So paper, if it comes out, it will come out from radiologist and not from the clinicians, because this patient moved from one doctor to other. We don't know what somebody has been treated, and that background history also we don't have. And so collecting, and you see every chest physician is so busy that he will not have time to collect the data also, honestly speaking. This is, I can tell you. Yeah. So because you are now taking rounds in COVID, plus you are doing this post-COVID patient, and plus your old load of TB and asthma. Okay. So this
is coming back now.
Coming back now. So now they started coming back. So it is, I think we should train radiologists and we should appoint people to help them to find out data on the role of Pirfenidone and role of antifibrotics in the improvement of the patient. That's my solution.
I think CT scans are being done right and left. In fact,
yes.
Even if we don't order, patient already has got it, and he just come up with the scan, and even if not ordered it after 2 weeks, he would again go and do it and say that this is increase or not. So I think I think that's a very important point that you have made. That I think if we can make aware of a radiologist, and if we can get some data from them, if we can match with their also treatment what was advised, I think we can have a wealth of information on this. So what are the exercises that you actually tell them post-COVID? To advise them to have after they have this COVID and they are on oxygen therapy, because if so we don't advise, then they would do all of the sorts of exercises like Kapalbharti, and I've seen also patients also doing Bhastrika, and then they say they also get a bit of problematic, and then when I say them to go for prone ventilation, then they say no sir, we have got this problem, when we did this thing, this happened. So do you think that they would need some guidance on which particular exercise would really be helpful for them in this patients who are stuck with oxygen, or still who have got basically dyspnea whenever they do some work, even after COVID is there?
Well, first of all, I don't advise any exercises to these patients. I hand over this patient to rehab team. That's number one. But yes, we do have meetings with the rehab physiotherapists regarding what they do. Okay, so each case is different. Remember, a lot of patients who have got anxiety, depression, lack of sleep as a predominant and a wasting of the muscles and fatigability as a main complaint, condition to be referred for a rehab program. You can't refer this to psychiatrists. Remember, okay, we have to the best people are rehab, and minor level of anxiety, depression, etc., or even moderate level of anxiety, depression can be taken care very well by rehab team. Okay, so that's number one. Exercises they are offering, but we have added certain exercises after experiencing it. One important thing is that there is a definite role of meditation over here. Okay, which definite role. Okay, because your mind drives the lung respiration. If you ask me, two important things that breath and the mind as relations. If you become anxious, you will be going to breathe very heavily, and if you are nervous or if you are sleeping, your breathing rate is low. So if this is going to drive, mind is going to drive breathing, then breathing also can drive mind, remember. Okay, so exactly reverse. So if you educate the patient and make them breathe very, very perfectly, okay, I mean the sense the rate of breathing can be reduced by techniques, okay, you will become better. Your anxiety will go down. Your psychological aspects will be, this is very important in that I've learned. So let it go to the rehab team. Now our rehab people are not trained in yoga. They are not you are trained in meditation. So now we have involved yoga specialists and meditation specialists to teach our rehab team about meditation and yoga. Now this is a rapid course of yoga and meditation. Remember, you can't replace by a specialist in meditation to come over here and to train because they require exercises also that our yoga people will not be able to train them. But interestingly, which I find that there are certain yogic asanas if you do, okay, like Parvatasana, then these asanas, and even Vakrasana, Chakrasana, these, and you concentrate on breathing, you will find that you can breathe from the upper lobe, you can have breathing from the apex of the lung, you can have breathing from the lateral aspect of the lower lobe, you can have breathing from the diaphragm with certain yoga and pranayam. So only thing is that they are not asanas, remember, they are breathing exercises. So when breathing is collaborated with asanas and you concentrate on breathing and not the asanas, okay, then you will get a benefit much more. Okay, that is an observation. Okay, so I think our physiotherapists should be trained in this aspect, which is the ancient but very important aspect. I feel they must know how Omkar, then the Brahmi pranayam should be done. They should know how to relax. Like for example, the Makarasana, which is a extremely relaxing position, and if you give this to the patient who are in having hypoxia, they really benefit. Okay, so this training is required, and our physiotherapy should be trained in that. That's what I feel. There is a role.
A very important insight you have given in this exercise, which of course we have to learn from other pathies. And also meditation is, of course, will go a long way, because there is a lot of panicky reaction which is going on in COVID, COVID patients, and they really fear. So that would be really good. So thank you guys. In fact, we had actually a very good afternoon with all of you having a discussion. There's important aspects. We are overshooting our time, so I think I'll hand over to Dr. Pankaj. Yeah.
Yes, sir. So thank you very much, and I would like to thank all the speakers who have taken out their time from their busy schedule, and it was excellent talk. So means we have started from the IPF and we went to SSC ILD, the other ILD, we went to for the rehabilitation discussion. We also discussed about the palliative care, and we have also discussed about the COVID fibrosis. So almost we have discussed holistically most of the things which are pretty exciting, and I think so all of our panelists also would like to know from all of you, means senior pulmonologists, what are your opinion on the same, sir? So with this, I would like to thank everyone, all the speakers. Special thanks to Dr. Swarnakar and the ICS team. Thank you, Dr. Sujit Rajan, and thank you, Dr. Prahlad Prabhudesai as well. So.